Hi, welcome everyone. This is Chris Romeo. I'm the Senior Vice President of MedAxiom. We're going to give this just a few seconds to allow everybody to register. So if you will, just hold on tight and we'll begin in just a minute. Okay, as we get everyone registering, we have a nice webinar today, sponsored by our partner GE Healthcare. It's EC management to improve operational efficiencies and outcomes. A couple of housekeeping items. All the attendees will be on mute and off camera. If you do have any questions for the panelists, you can enter them. There's a Q&A button on the bottom. We will be monitoring that throughout the webinar, and we'll be posing those to the panelists at the appropriate time. So with that, let's get started. We've got two physicians and Jamie Warren, who is from MedAxiom, Dr. Deshmukh and Dr. Bhavnami. If you will, let's get started. And thank you again for all joining us today.
Great. Thank you, Chris, and welcome everyone. So my name is Abhishek Deshmukh, one of the electrophysiologists at Mayo Clinic, and I'm going to talk to you about some of the recent and the upcoming changes, what we can glean from an ECG, and overall how good ECG management, portfolio, suite, and technology can drive better outcomes and intervene on cardiac disease sooner. These are my disclosures. So I'll start off with the case of Mrs. F, who is a 62-year-old, generally a fit banker, no exertional chest pain, no major really symptoms, and acknowledges generally being worried about her health when she found out that both her sister and sister-in-law had some cardiac issue. One unfortunately had a heart attack, the other lady had a stroke, and she was just getting more worried about it and was wondering whether she should be screened for any heart condition. Now, the options in today's time to screen any cardiac condition is, ask Google and describe all the symptoms you're having, or go and see a doctor, have them do a stress test. If the stress test is negative, then worry more about it, or wait for something to happen and then see how things go. But if we have a good screening program to detect the undetected cardiac ailment, which is reliable, feasible, valid, has good performance, and very, very effective, then it can go a long way in preventing that first heart attack or first death or first sudden cardiac, first death or first stroke. And when we think of a screening program, if we get the answer, then there are certain risk factors the patient may have whom they can modify and see if they can reduce the risk of having any of those sequelae of all the comorbidities the patient has. But few things will never change. One is the evolution, the fact that we are born, that means one day we are going to die. But the evolution has been changing in a way which is not extremely healthy. And the death is inevitable because in the end, all of us are going to get cooked. So before this step, if there is a way we could intervene to prolong our longevity, prolong our age, and prolong to have a good, fruitful life, is going to be crucial. So that's where ECG may play some role. So normally when you look at any patient, they feel great, but then, at some point they develop some signs and symptoms. Based on that, they get diagnostic testing. And then, even if the diagnostic testing is negative, we have always heard that somebody was quite healthy, but still had their stroke or heart attack or unfortunately died suddenly. But these things don't happen that suddenly because over a period of time, there are certain metabolic and physiological abnormalities which are getting developed over a period of time. And if there is a way to detect that, we may be able to avoid some of these events. So if you just look at the most common cause of sudden cardiac death, it is low ejection fraction on somebody having an abnormal heart. So it is seen in about 2% of global population. About 7 million Americans have it, and about 9% of them tend to be older than 60 years of age. And now we have definite medications and device therapies that if the patient is taking appropriate heart failure medical management, has a device in the right situation like an ICD, it can lower mortality and hospitalization. But to identify that asymptomatic patient, you'll have to do an echo on 9% of human population in America who are above the age of 60, and that may not always be feasible. So is there something else we can do? Well, if you look back at ECG when it was in first recording was made in 1895 by William Einthoven. About we are getting close to his 100th death anniversary now. This was the signal from the ECG. But this signal, what it really depicts is the voltage coming from each myocardial cell, and that gets amplified by all these recordings placed on the chest wall and to get this ECG. And now we can use this ECG through newer analytic tools such as neural network by analyzing a normal ECG and abnormal ECG and then train the model for several things. So one of the first iteration was to train the model to look for the pump strength or the ejection fraction or how good or bad the heart muscle is squeezing. And what at least we noted when we had done this study at Mayo here a few years back, that the prediction is pretty good to predict a low ejection fraction from a normal looking ECG. The key thing is a normal looking ECG. So from a normal 12 lead ECG, if you can predict a patient having low ejection fraction, the AUC for that was about 0.93. And if you compare that with some of the other screening methods such as pap smear and mammogram, the prediction of low ejection fraction actually favors quite a lot and works pretty well compared to the standard screening what we have. And this we implemented in a clinical trial done in the Mayo Clinic Health System and Mayo Clinic. About 22,000 patients were whoever had a normal ECG were enrolled, and they can go to any clinic, and then we applied the AI algorithm to detect for a low ejection fraction when an echo was not actually planned, and the AI ECG selected high risk individuals for echocardiogram, and based on that the echo was performed. So if you add that AI component piece to the ECG, we are more likely to diagnose that patient with low ejection fraction. The patient may not be very symptomatic, may have vague symptoms, but now that we have diagnosed it, we can, offer optimal medical therapy. So this now, has an FDA breakthrough tech. FDA is approved, and in 2025 now there is a billing code for AI ECG to predict low ejection fraction. So now let's look at this ECG. If somebody looks at this ECG, it looks pretty normal to me, maybe some baseline artifact. It is actually my ECG. And this is how it will look in practice when you apply that algorithm that low ejection or low LVEF is not detected, low left ventricular ejection fraction is not detected. So quite reassuring. Now, apart from low ejection fraction, we can look at several things now that we know how to analyze neural networks, applying neural networks to look at these ECG signals. So this was an 85-year-old gentleman who was doing fairly well for his age, had ischemic cardiomyopathy and an abnormal ECG suggestive of left bundle branch block. And the question was whether we should offer him a cardiac resynchronization therapy with a defibrillator. So a shared decision making was made. And his main symptoms, despite being quite active in life and having several vacations, he just felt he was getting old. So now from a 12 lead ECG, you can predict the age of the patient. So the patient actually was 86 years of age, but the AI thought that the patient was 81 years of age and very high probability of having low ejection fraction. The patient gets that CRT defibrillator therapy placed, the ECG changes. Now the probability of low EF goes down from 75 to 61%. But look, the age is now goes down to 70 years from 80 years what the patient had. This is the AI age. This is which is looking at the physiology or the biology of the patient and describing what the age of the patient would be. The patient came back in clinic after the device was placed with a completely normal ejection fraction and did very well. And now the probability of low ejection fraction was only 9% with the fact that the echo has showed improved ejection fraction. So you could have predicted this even without getting an echo. And now the patient's AI age is 75 years when the real age is 86 years. And guess what the patient says? I feel 10 years younger than what I felt before. So again, looking at the age of the patient, we can, offer therapy because not all 80-year-old patients are, feel like 80. Some 80-year-old patients feel like 60, and some 60-year-old patients feel like 80. So looking at the actual biology and the protoplasm of the patient from a 12-lead ECG, you can potentially figure out what is the actual physiological age. Same thing, you can look at the gender of the patient from the ECG. So, and this is also has some value. So now I'll show you a trend of age. So this is the real age of a patient, and this is the AI ECG age of the patient. And when the patient was actually 53 years of age, the AI called the age to be 70 years. And then some intervention occurred now that the patient's age went down to about 35 years. So something really changed when the patient was 53 to start looking quite young, few years down the line. So what could happen? Maybe he had Botox therapy. Maybe he had a hair transplant. Maybe he had, had a new partner in his life that is making him feel young. A lot of things can happen. But what really happened in this patient was a heart transplant. Patient got a heart transplant, suddenly got the heart of a young patient, and then the AI age went down dramatically as the patient felt really good. So this AI age is currently used in a lot of situations such as social isolation, acute illness, a marker for obesity, premature vascular aging, and certain other conditions where actually the physiological age of the patient can accelerate much more than the real age of the patient. Now, with all this, does it actually work in practice? We have big data on this. We have biological signal that it works, but can it actually work in practice? So at least at Mayo Clinic, the way we have integrated in our electronic medical record, that we have created an AI ECG dashboard. Based on that, when you click it, you get all the serial ECGs of a patient. And now we can look at low ejection fraction, hypertrophic cardiomyopathy, probability of AFib, aortic stenosis, amyloid, age, gender, and few other algorithms looking at diastolic dysfunction, coronary artery disease, pulmonary hypertension, potassium are under investigation to get it deployed. So coming back to my ECG, low EF was not detected, but some of the other things were low risk for hypertrophic cardiomyopathy, AFib, and didn't have much of the other comorbidities, what I don't have. But what I really loved that it called my AI ECG age less compared to what my real age is, and that made me feel quite better despite losing some hair more recently. So when in, Greece, we always think about, what actually, the Greeks would think like. So when we look at AI, for example, so Socrates would ask questions until people saw the truth. That's like explainable AI. Plato believed in ideal forms that existed beyond our reach, and that was sort of like predictive model, which never fits in theory. Hippocrates' oath, like all physicians, do no harm, and that is definitely a AI algorithm motto who will get a treatment or a device. Icarus flew too close to the sun, and that's what happens when you train an AI model on a very limited data set. So now, now the fact that we know AI works, we need to make sure that the AI works in a more legitimate way, in a prospective way, in a way that it is uniform and more democratic, that a lot of people around can get access to that. But if you're still skeptical, and I don't care what it looks like, it is still backwards looking at this, whether this is the head or the tail, and whether this is the head or the tail, now we need to have better way of messaging that data. So now on physical exam, if you examine that patient, you can figure out a murmur and then order an echocardiogram. But the challenges there are, you could pick up that murmur later. Not everybody could hear that murmur. And if you hear that murmur and if you get an echo, it may take some time to get an echo or any other condition, because 11% of imaging expense of Medicare is for imaging, and it can be inconvenient. So now what we are trying to do is to apply this AI ECG and do a point of care ultrasound. So the way it works here is the ECG is performed by the tech. If the AI alert is there for any condition, a novice operator performs a POCUS, and this is the quality of the echo which we are getting, but reasonable enough sometimes to call whether the heart is abnormal or normal. And based on that, you can look at who has low ejection fraction. So really to predict, to pick up one patient with low ejection fraction, number needed to screen is about 200 when you look at a positive AI along with the echo data. Now that fact that we have a CPT code, efforts are being underway how to get it best in practice to identify who will be the right patient to do it and to apply this algorithm. Because if the patient already had an echo scheduled later in the day, there's no point asking the ECG what the ejection fraction is going to be. So we are trying to work on identifying the right use case scenario. So at Mayo Clinic, we also have an AI ECG core lab, which is open for research to look at any of these conditions from a 12-lead ECG, such as prediction of AFib, hypertrophic cardiomyopathy, age, gender, amyloid, cirrhosis, and among many, many things. And if you are interested, you can certainly reach out to us, and then we can work on it from research standpoint. So in conclusion, there is definite clinical utility with current workflow, and if it can get integrated well in the current clinical care and EHR, I think it's going to be a huge plus. It can clearly predict and detect disease. It can even do that before the patient has that disease. And just from a 12-lead ECG, it has, you can scale it all over the world as long as somebody can get you an ECG in a digital format, which can be analyzed from the AI. And this, I think, really is going to drive practice and innovation over a period of time, especially in the resource limited areas, or in areas where access to getting the next best imaging modality is not available. I think certainly doing an AI ECG can be a good clinical nudge for the provider to order the next test, or to at least look in depth whether the patient actually has that pathology or not. So I think I'll stop here, and thanks a lot.
Thank you, Abhishek. Thank you to our organizers at MedAxiom GE. Abhishek, I should have included a lot more humor into an economic talk, but very much enjoyed and look forward to our Q&A. Pull up my slides. My name is Sanjeev Bhavnani. I'm a senior consulting cardiologist at Scripps Clinic, and today we'll go over how good ECG management and technologies can optimize a cardiology practice with a specific focus on health outcomes and economic benefits. These are my disclosures. So what we'll cover today, right? We'll take a page out of Abhishek's book and continue forward on economic shifts in healthcare delivery with ECG technologies. We'll go over some models of care integrating such technologies with real-world examples of how they're integrated into healthcare delivery. We'll look at some consumer healthcare screening, point-of-care detection of arrhythmias, remote patient monitoring, transitions of care, high acuity care into the clinic, and some value-based care and bundle pathways. We'll try to drive the economic value of early detection of arrhythmias, and we'll discuss some implementation keys and some future AI applications with how AI can transform process delivery in cardiology clinics. So no talk about the economics of cardiology would be complete if it didn't start with the aging population. And I didn't know this until recently, but there'll be more older adults than children in the United States by 2030. 1 in 5 Americans will be above the age of 65, eclipsing nearly 100 million people in this country. So there'll be a much bigger demand for healthcare tailored to unique and complex needs. So payment models, right? So if there's a need for deriving more value in care and to deliver more healthcare, we need different payment models. We are established and we know about fee-for-service, payment per service provided, but value-based transitions in care, payments tied to quality of care, capitation, payment per patient per period, and then bundled payments, single payment for entire treatment. I think all of these apply now to digital technologies and AI that we'll get into and after the presentation as well. But how do we now leverage new technologies in expanding payment models for cardiovascular care? So if you look here on the left, we're all familiar with patch-based ECG monitoring technologies and Holter and telemetry devices. And if you look, there's many devices available now, and they do an exquisite job with ambulatory cardiac rhythm management. But these last 10 years have really seen a boon in consumer medical devices and ECG wearables. Smart devices, smartwatch devices, light sensors on the back of a phone that all have been successfully regulated as available devices for ambulatory and consumer-driven rhythm detection. There's new point of care ECG arrhythmia detection devices in stethoscopes. And while the video doesn't play here, there's emerging non-contact arrhythmia technologies with remote PPG, camera-based, non-electrode-based detection of a normal or abnormal rhythm through remote PPG. So we have some questions, right? We expanding portfolio of new technologies, But we have to come back to and ask, does the technology work? What are the technical and organizational factors? How do people interact with the technology? What's the coverage? What's the adoption? How does the technology improve the process? Is it available? Is it cost efficient? Is there quality of care? And how do improvements in service delivery affect health? And that's improved health outcomes and economics. So let's look at some real-world examples and economic implications, and these are from practice. So the economics in general of patch-based ECG monitoring also goes without needing to explain much. The market size for patch-based and Holter monitoring continues to increase. So which segments in these populations will economic benefit be most from digital and AI innovations? And I highlight three here. AI-driven analytics benefit from improved workflow automation and improved decision-making. And we saw Abhishek present some on the ECG dashboard. Healthcare applications utilize AI for diagnostics, prediction, and patient engagement. And R&D. Is there a benefit of AI-assisted data modeling and trend analyses? And I'll show a specific example around AI-driven analytics. So the growth of remote monitoring, right, remote patient monitoring, since it was approved and legislated by CMS in 2018, 2019, nearly 1 million Medicare enrollees have received remote monitoring in 2024. The payments for remote monitoring have increased 31% from just the year between 2023 and 2024. And this market size also has a greater than 12% annual growth. And if you extend out to 2030, in excess of $50 billion in healthcare expenditure for remote patient monitoring. So with this expansion is also the expanded CPT coverage for remote patient monitoring, remote therapeutic monitoring, and chronic care management. This is just an example of selected CPTs with some of their descriptions for how clinics can get onboarded with a remote monitoring program. The initial setup, patient education has a reimbursement associated with that. Device supply, the amount of time now that a physician dedicates or an advanced practitioner dedicates towards treatment and management remotely, so non-face-to-face in virtual care. Now, important things to remember, our Medicare payment rates are based on work RVUs, geographic practice cost index, so there is a varying rate based on geographies, and this annual conversion factor for a national fee average. Things to keep in mind for those who are interested in getting RPM off into their clinics. As we look at CPTs, we also have to think about systems approaches and clinical integration approaches. And this is just a short list of things to consider. How do people access devices? Is there a third-party digital health or machine learning data system? An independent diagnostic testing facility that does the monitoring reporting? What are the clinic's settings? Federally qualified health centers, value-based centers, population health, VA. All of these matter. And then how is the data integrated into electronic health records? What is the data cycle? What is the data transfer from home into clinic? And there are many requirements here. There's the HIPAA privacy security requirements, but also HEDIS requirements for ensuring that a certain number of measurements are obtained per month in order to provide care and bill for those services. One key integration value and is of the Muse platform. How do we bring ECGs that are in clinic that are already established into Muse, but also ECGs that are now performed in the ambulatory outpatient setting to also be integrated into a centralized ECG repository for physician review? So let's look at some specific examples, and I'm going to go through a journey here of risk. Let's look at a low-risk monitoring scenario of a 48-year-old woman with palpitations and no history of cardiovascular disease. So this is a consumer-driven model of arrhythmia care. She's purchased a smartwatch that can track ECGs, symptom-tracked ECGs. So it's a consumer wearable as an alternate to a prescription patch-based device. And in this particular person, all of her rhythms, right, when she has palpitations is sinus. So there's long-term symptom-based monitoring, but use a consumer device instead of a prescription patch-based device for a low-risk person who continues to be in sinus rhythm during symptomatic episodes. So there are economic implications here. Healthcare savings through the use of suitable technologies based on low risk of an arrhythmia, and healthcare savings through patient-acquired ECG devices in comparison to the expenditure associated with Holter or telemetry monitoring. Another example. A 76-year-old gentleman with paroxysmal atrial fibrillation who goes in and out of rapid atrial fibrillation tracked remotely, right, through rapid AFib and sinus rhythm. It offers the opportunity to also interject treatment, to interject suggestions, right? What needs to happen to this person in order to control atrial fibrillation, but also understand their triggers. In this particular individual, an integrated model of remote patient monitoring led to a time to AF recurrence to identify the time to a treatment decision. And in this particular person, it was for a referral for cardioversion and then subsequent ablation. But the economic implications here are that remote patient monitoring enables an earlier time to treatment and averts unnecessary healthcare visitations, right? Emergency room or hospitalization that might otherwise have occurred should this person not know that they were in atrial fibrillation or not. Here, high-risk monitoring the transition of care. A 79-year-old gentleman who was recently in an emergency room visit and scheduled for cardioversion as an outpatient. So he is in atrial fibrillation, right? And remote monitoring at home, right? He converts to sinus rhythm. He converts to sinus rhythm at home. So it led to a different treatment decision now. Had the economic implications here, and if him converting to sinus rhythm, which is good for his overall quality of life and for symptoms, but had he presented in sinus rhythm, the procedure would have been canceled and he could have gone to and cardioversion could have gone to another patient. So there are implications here for patient and clinical workflow efficiencies. And finally, one example of opportunistic screening at the point of care. Silent atrial fibrillation can occur in 2 to 4% prevalence. In primary care, data has been shown in primary care, cardiology clinics, and even in community pharmacies. But the use of rhythm monitoring technologies in order to produce a sixth vital sign of a cardiac rhythm recorded at the time of a clinic visitation. There are CPT codes associated with this for 1 to 3 lead performance and interpretation and reporting to know if in elder clinics or in populations where atrial fibrillation is more common, the opportunistic screening for atrial fibrillation. Right? It may be cost effective when downstream stroke prevention is included. It identifies high risk for further testing and treatment. Let's talk about another side now in opportunistic screening, right? Now done in community settings, in people at home with consumer wearables. Now, there has been data, and some in the audience who have seen this in clinic, false atrial fibrillation alerts. And we discussed the economic implications of detection. There's also economic implications of false positive detection. And so while it's very important, a decreased perceived well-being in individuals who may have false positive detection of atrial fibrillation, there's also low diagnostic yields in such individuals where the prevalence of atrial fibrillation is low. And in this study, um, diagnosis of atrial fibrillation in people who screened positive was less than 12% of patients. And those who presented to emergency rooms, to hospitals, to urgent cares, or to clinics, right, led to excessive healthcare resource utilization and anxiety. Some of these common tests on the left that we do in practice may be offered to such individuals who have a wearable detection of atrial fibrillation, right, where they might not otherwise have been necessary. So the approximate cost of false positive results can range from $300 to over $2,500 per false positive patient presentation, and this being computed from the results of this study. So clinic level cost benefit considerations. We talked about device level cost benefit considerations, but for clinics to consider the upfront costs of device acquisition, IT integration, staff training, technical fees, payer reimbursement, and profit margins per patient cohort. The cost drivers per patient is the device and platform to acquire those. Are these affordable? Can they be used in resource-limited settings in lower socioeconomic communities? The staff time for monitoring and admin, there is a human capital expenditure associated with monitoring people at home. And then from the clinic, IT, EMR integration, and any subsequent overheads. So are we in a paradigm shift now, right? Shown and Abhishek has also shown a plethora of devices. Is there a future where we can see symptom-triggered ECG transition to patch-based monitoring when arrhythmias may be detected in a higher incidence? And as we look at the economic implications of patch-based and ECG devices for AF screening in such models, in screened cohorts who are at high risk, so in here, almost 2,000 study subjects in the mSToPS study with a CHADS-2 vascular score of 3 who were followed for 3 years, who underwent screening with a 2-week patch-based monitor, there was a lower rate of ED visitations and hospitalizations due to AFib and stroke. So there was an incremental cost-effectiveness ratio of $17,000 per quality-adjusted life year gained, well beneath the threshold in the United States to consider coverage for screening. In a simulated model, right, using all different types of atrial fibrillation screening strategies, point of care, short-term, long-term, monitoring in ambulatory settings, the most effective cost-effective strategy was confirmation patch after, in this case, PPG-based atrial fibrillation detection, which one could substitute with ECG-based atrial fibrillation detection at a $57,000 quality per adjusted year life gained, largely attributed to the lower incidence of stroke. And while these data are promising, right, we are eagerly anticipating the study results from the REACT studies and Heartline studies to establish screening and treatment, right, in individuals who screen positive for atrial fibrillation. So forward-looking, right? AI ECG technologies and economic prospects. Here, an example of a 12-lead ECG in sinus rhythm. There are AI algorithms that have been approved that analyze a 12-lead ECG, right, for the future development of atrial fibrillation, the future risk of atrial fibrillation. And so in a hypothetical scenario of a 65-year-old man with no known history of atrial fibrillation who's in sinus rhythm, should we use an AI algorithm that analyzes this sinus rhythm ECG and it outputs that this person has a high risk of development of atrial fibrillation within 1 year? And there are general CPT codes that Dr. Abhishek had gone over as well that are available for use, but we have some economic considerations to start discussing about this. Should this person who's screened positive for high future risk of atrial fibrillation undergo downstream testing? Loop recorder, smart device ECG. Should this patient undergo a CBD and CAD risk assessment? Should they be offered antiplatelet therapy, right, as a prophylactic measure? How do we ensure necessary and appropriate use of healthcare resources that drives economic value as well? And I hope we'll discuss some of this in our Q&A. Finally, a study that we participated in with Linda Johnson in Sweden, artificial intelligence for direct-to-physician reporting of ambulatory electrocardiography. So the aim of this study was to compare an AI-based analysis of ambulatory telemetry arrhythmia detection to human technician analysis for reporting of ECG findings. So telemetry used at home, an arrhythmia is detected, an ECG technician verifies this and then reports to the physician. This is the conventional way of reporting ambulatory telemetry monitoring. Well, how would it look if an AI algorithm did the detection, reporting, and then communicated directly to the physician? Is there a possible replacement of our workflow with an AI algorithm? And in this study of nearly 15,000 individuals across 2.5 billion annotated heartbeats, read by a large group of cardiologists to evaluate true positives, false negatives, and true negatives, the yield, right, of an AI algorithm to do automated arrhythmia detection and then reporting to physicians. And the concern is of false negatives. An AI algorithm should not have missed arrhythmias with AI in any more frequency than a human technician or a cardiologist. And what this AI algorithm showed was that there was a 14 times lower risk of misdiagnosis than technician analysis, with a slight increase in false positives. But the negative predicted value for a critical arrhythmia was greater than 99%. So an AI algorithm can automate the detection of arrhythmias and then report to a physician. So is there clinical efficiency and economic savings with the use of AI now used within the process of ECG and telemetry delivery, right? And these are important areas as we see artificial intelligence extend now into communities with new technologies and into new clinics. So in summary, we've gone over the clinical and economic shifts in arrhythmia detection, reviewed some real-world models of using remote patient monitoring. We outlined some of the risks of the false positive arrhythmia notification on healthcare expenditure, economic drivers and clinical cost-benefit considerations, and then some hopefully provocative examples of AI as clinical efficiency tools for arrhythmia detection and monitoring. Thank you very much and look forward to our Q&A.
Thank you to both of our physician speakers. Both presentations were absolutely fabulous. If we have not met, my name is Jamie Warren. I'm part of the care transformation team here at MedAxiom, and we'll be assisting with the Q&A section here. For our participants, down at the bottom of your screen, you'll see a button that says Q&A, and if you will enter in any questions that you have. But again, thank you to both of our physicians for your time to be able to get your thoughts and your recommendations as our questions come in. Excuse me, selfishly, I have a question to kind of kick us off first. And I would ask, if you were advising a cardiology practice just starting to explore AI ECG, what is the single most important step that they should take to set themselves up for success?
So it's a great question. And, as we see more of AI getting integrated into practice, we need to see how and why and where we need to use the AI. So from a cardiology standpoint, how to best integrate the models in practice through the ECG software viewer, what you are using, or software viewer for ambulatory monitoring, and what it is going to add. Now, generally, if somebody is seeing a cardiologist, they would get an echo and they would get a lot of things already done, before they meet a cardiologist. But where it can actually work is that, if you're, at least the way we use it sometimes is, say if somebody gets an AF ablation today and they do fine for 3 months and they have a follow-up coming up in a year. So if that follow-up before that, we get an ECG and we look at prediction of AFib from the ECG, and if there's not much prediction of AFib from an ECG, we can potentially skip that extended monitor what the patient is wearing, just make it more comfortable and easier for the patient. Especially in today's time, a lot of our patients do have access to a smart digital tool at home to look for that ECG. Other places we can look at this is, say you are evaluating a patient for shortness of breath and you order an echo, but the AI ECG say prompts you to have it might be amyloid. So at least in your mind you're asking the right history to the patient, whether they have tendon rupture or few other clinical history to kind of piece it all together. So I think there is clinical value in that. Now, down the line, it also becomes helpful from triage standpoint, because, if the patient sends an ECG, based on the findings, what you get from the AI overread, whether that can be triaged to an earlier or a sooner clinical appointment, whether based on that you can reduce heart failure related hospitalization, all those things, we will be learning more and more about it over the next few years. So I think there's a lot of promise. And then I envision in few years there'll be more algorithms and more different kinds, more people will put out their own algorithms to see how it's going to work out. But at least for now, the fact that we have an FDA approved algorithm, you might consider getting it integrated into practice, test it and see how it works. And beyond cardiology may have a lot of implications in ER, in primary care clinics. Somebody gets an ECG, now that you have an alert for a particular condition, then at least they can be sent to a cardiologist sooner before they actually get that pathology overtly seen on an imaging study. I think it has a lot of promise, and I hope next decade or so we are going to see a lot of progress and innovation in this space.
Thank you.
Thank you. I can add a little bit. Thank you, Jamie. Thank you, Dr. Abhishek. to clinicians who are interested, understand the problem that you want to solve, right? And then use AI to solve for that problem, right? So these AI algorithms for early detection or AI algorithms for process efficiency. And now take the stepwise approach for ensuring good quality management, healthcare resource use, understand what the clinical workflows are, right, by using AI. And when aligned with the problem that needs to be solved, and once a system of care comes into place, well, then the outputs can become actionable, right? Whether those are positive or negative outputs. So definitely a good process. Look at clinics as how can AI improve process efficiency, right? Centered around what is the problem that is trying to be solved.
So we've had a couple of great questions come in. I'm going to read this first one here. It says, how do you build trust with clinicians who may be skeptical about AI outputs, especially when it challenges what they see on a standard exam?
Great question. And if you remember the slide I had shown about the dog with glasses on its tail, it's basically whether you actually believe what is being thrown out from a model. And that is going to be a mindset change for us also. So maybe like 20 years back when we would put something in a search engine that to look up something, we were always very skeptical. But as that search engine got better and better, we started searching better things. We know how to search things now. We have started to gather more trust in the search engine or online tools when we look at it. And same thing will happen with an ECG. So, if you look at 20 or 40 years back, when echo came out, the people were still concerned whether this is actually a low ejection fraction, but we started gaining trust in that. And same thing is going to happen with AI when the AI will be more explainable AI, where anybody who sees an output will have one more layer of security to that, say from a point of care ultrasound, say from another tool, say voice recording, and then see whether it can combine everything to get you a more result, which is more specific and has a higher negative predictive value. Because right now, the way AI is going to be used is more of a rule out test or a screening tool. And then, as we move along with scale and innovation, we are going to make it more fine tuned. So just think about how troponin level came out. If all troponin levels elevated does not mean somebody's having a heart attack. But now as we started to gain and understand more, it has to be a combination of several things. So hopefully the future is going to be a combination of an AI output, your clinical judgment, exam, and maybe a limited imaging study which can help you diagnose that condition.
Anything to add?
Yeah, no, Dr. Abhishek highlighted it very well. I hope cardiologists do what cardiologists do very well, and that is always understand an output in relation to the risk of the person they're seeing, right? The field is very familiar with false positive, false negative findings on stress testing, on echo, on other tests, right? And therefore the yield is never 100%. And so if ever there is a discordance between an AI output and what is expected, well, then that really falls into the practice of cardiology, right? Where there are questions as to how did the AI algorithm produce that output? That's a very important question for people to ask, right? Don't take it at face value, but also in the context of that patient, right? And so rather than the implicit anchoring, the anchoring and the bias that happens with any AI output, but just fall into good practice models, right? On ensuring the right output for the right patient. And that should lead to scale, we hope. And we will see, especially over these next few years.
When we start to talk about AI, the thing I always like to think about is this is a collaborative tool. This is another thing that's in our tool belt that we can work together to ultimately get the best result for that patient. So it's very interesting how it's becoming more and more prevalent as we're moving forward, especially in the imaging and diagnostic space. Okay, our next question. With the development of personal devices, how do you manage the amount of data? Oh, the amount of data and align with your billing practices?
Well, I'll start here. Great question. Very difficult, right? Every practice is different. We alluded to, right, that really understanding the problem that you want to solve and develop a system around that, right, for clinical efficiency. When it starts like that, then there can be the opportunities to be able to filter signal from noise, right? So a lot of alarms, a lot of detection, a lot of results and measurements, but developing as best as clinics can, a standard operating procedure, right, for remote monitoring, and really have a shared decision making with patients on what are the expectations here, right? For once weekly review of data, once monthly review of data, right? But so long as there's a good transparency around that and what is feasible for a clinic. We've had scenarios, and I recall this over the years of receiving, maybe over a dozen ECGs in a day, right? And that is, of course, welcome, right? Because it's concerning that individual, but we must have the capabilities in our clinic to be able to review and then provide assurance, right? Or a treatment decision for that person. And that is good clinical efficiencies, right? So over time, what we've also seen is there can be a more efficient process and a more efficient use of devices, right? In the beginning, a very good shared decision, hand-holding partnership, right? That can become looser as time goes on, where people understand what is the device actually detecting. Like a watch doesn't detect a heart attack, but it is commonly, a concern of people when they have symptoms, right? So that's an ongoing partnership for process efficiency.
Great.
I agree. Very well said by Sanjeev. And it's tough. Whenever people would send their initial tracings on any smart tool at home, it was being more of a service that the cardiologist or the provider was offering more of that concierge touch to that patient's question. But as we are getting more and more data deluge with this information, we need to have more streamlined approaches to see, is there a way to integrate that into actually electronic medical record system, part of the ECG viewer software, what you have, and then maybe potentially even start, billing for it. Because, if there's a tracing coming out, if the tracing is clean and clear, whether we could start billing for that. And again, as the CPT code matures for some of these tools, I think we could see a paradigm change in the way things are being done, so that the patient need not drive to the hospital to get an ECG, but certainly could send something from a limited lead set from home and get it analyzed.
Absolutely. Our next question, do you see any ECG algorithms being leveraged to diagnose beyond arrhythmias, such as coronary or valvular disease?
I can take that. So there are ECG algorithms which are designed and available, not for commercial use yet because they are not FDA approved, but at least in the research arena to predict aortic stenosis, like moderate to severe aortic stenosis, to detect coronary artery disease, to detect pulmonary hypertension, to detect dyskilemia, amyloid, hypertrophic cardiomyopathy. So several pathologies who do have a discrete ECG signature before it develops. I think there are several algorithms out there to look at it. When you look at these algorithms, also important because you can develop your own algorithm in no time, but you really need to get it more validated through independent data sets. Make sure that it has a good sensitivity and specificity, because when you put it out in practice, again, people should believe, as one of the first questions which was asked, whether it is going to be a believable AI and actionable AI. So, the algorithm has to be very well validated. And then, I think if it works out, I'm pretty sure there's going to be a lot of excitement to use those algorithms.
Yep, and we can continue to build upon, right, the use of cardiology AI algorithms, which is second only to radiology, right, in the numbers that are available. But AI plaque phenotyping analyses on cardiac CT is a very good example and one that we use and to better understand coronary artery disease. And so there is a lot that established models, right, that have been here for the past few years of where new AI algorithms, right, that are ECG based or non-ECG based, right, can also leverage the successes of implementation and integration. But AI plaque phenotyping has been a very interesting one, and also interesting from a patient education perspective, right, to be able to share information on what coronary artery disease is through an AI analysis, it's also a very good opportunity for cardiology practices now to integrate and include, right, as part of their treatment plans for such patients.
Absolutely. So our next question is kind of a little bit of a lessons learned. So if you were to look back over the last couple of years to where your program is today, what would you say are like the top 2 changes that you wish you would have made sooner?
So do you want to take that first? Yeah.
Yeah, let me think about that for a second, right? There was so much learned over time, right? And when one looks back, right, you know, how do you get from, a handful of clinics to a division use of AI or digital, right? It's a completely different question to answer, even in scaling in one's own, in any institution. Um, what are the revenue drivers, right? The revenue cycle management and drivers for a positive gain or net neutral, right? When you continue to use these technologies. So I think having asked those, if we ask those questions earlier on, a lot more would have been learned, right? And perhaps some things averted, right? With how do you get from 20 patients a month to 200? And there's a lot out there, right? From developers and, about getting to such numbers, but it changes how a cardiology practice functions, right? And so how do you design for that? And I think now those are good questions to ask, right? For these next few years. But certainly a lot more learned than we ever thought possible.
No, absolutely. At least looking back in medical school when we taught an ECG, we, learned how to read an ECG. We are still learning. But now if an algorithm can pick out things which are unseen from an ECG, it's really a game changer. So it's almost like a very a unique and not so threatening way of a lie detector test, putting on the ECG to see, what you can actually find out from that ECG to, see what's actually hidden inside that patient or that human who gets an ECG.
Abhishek, I'd love your thoughts here, right? But of having more physicians, even junior faculty, senior faculty involved in AI, right? That understand how the pieces come together, right? What's in that black, quote unquote, proverbial black box, right? But there's also that, education, right? And experiential learning, right? As people start using AI. And that might turn out to be one of the more efficient ways. If you know what the ingredients are, then you know what to expect.
No, I completely agree with you. I think it is evolving more from a party trick to like a more like a just to see whether you have low EF from an ECG to see how we can actually integrate that into more practice, make it more believable, and actually makes an impact on the overall healthcare and the patient. So I think there's a lot of exciting things going to happen in the next few years, which are already happening as we see in around.
Absolutely. We have to catch up to our patients now, right?
Mhm.
People are using, LLMs and, and GPTs, right? For really everything related to their healthcare. So there's a shift now, right? From push and pull. It'll be very good that our patients pull us, right, towards the future. So yeah, absolutely. We're in this paradigm shift.
So we're down just to the last few minutes, and I think we have time for one more question. And I'm going to put you on the spot for just a bit here. So from a physician perspective, how can you provide recommendations to your peers on helping with getting this through IT when you want to add different AI products? Do you have any words of advice?
Yeah, so I think working through IT is important because this is AI for ECG is a software as a medical device. So it is a software solution. So first of all, working with the ECG reading pool, try to integrate that into the ECG software, whichever people are using, and then working with IT to see how you can integrate that output into the electronic medical record. And then from the electronic medical record, if there's a CPT code as we have it now, if you're going to bill it, then how to send it across to the patient and explain to the patient the result and all the downstream testing or lack of testing which is going to occur is really going to be the way I see this is going to evolve. So I think first step before we get IT involved is the physicians to really test it out, try it, and see whether this is going to add value to their practice, and then work with the local IT ECG reading group and then get it integrated into practice. But it is not only cardiologists who gets affected by an ECG. Actually, if you look at the most number of ECGs are performing in the emergency rooms, they are performing the pre-op clinic. So you need to have a buy-in from everybody in that hospital network or system to get it integrated. And then, as we learn more from it, then identify the best case scenarios to use it. So I think the cardiology practices would probably champion the cause of it, but they probably might be using it the least, because by the time they see the patient, a lot of this testing would have been done. But at least it's the first line, where they meet the patient in the ER or internal medicine clinics, where it is going to have the maximum impact.
No, Dr. Abhishek thoroughly covered, right? This is collaborative, right? And one new implementation of something has an entire process around it. So no, I absolutely agree with everything Dr. Abhishek said.
Yeah, I would just add another note to say work with your vendor. They do a great job of also providing you the information that you need, that IT may need to supply. So I just want to give the biggest thank you to you both. You guys have been great providing us your thoughts, your recommendations, and your presentation. Here towards the end, I'm going to turn this back over to Chris to wrap us up.
Thank you, Jamie. Real quick, we did record this webinar. We'll be pushing this out via our numerous channels. We'll also be sending a copy to all of our attendees and registered guests for the webinar. I do want to thank our panelists, Dr. Deshmukh and Dr. Bhavnami, as well as Jamie Warren, and especially GE Healthcare for sponsoring this. With that, we're going to bring it to a close. I hope you all have a great afternoon.